Hello everybody, my name is Matthew Simone from Empire Surgical, and today I'm going to be speaking to you about an anterior medial procedure of an ACL reconstruction surgery. Now, talk about the anterior medial procedure. Doctor will make his tunnels in a flexed position, so the knee will be flexed. An anterior medial will start on the anterior medial side of a tibia, and the tunnel will run up through the knee joint and out the lateral side of the femur. Now, those two tunnels, sitting like this, are completely independent of one another. They do not have to be on a specific angle. They are completely independent of each other, and that works. Now, for the ACL procedure, the doctor will start by putting his scope into a lateral portal. When he puts the scope into the lateral portal, he will identify all landmarks of the knee joint. These landmarks are the lateral and medial femoral condyles, the intercondylar notch, the articular cartilage that sits on the distal end of the femur, the ACL ligament, the PCL ligament, the tibial plateau, and the lateral and medial meniscus. After he identifies all the landmarks, he will then insert his probe in through an anterior medial portal and then begin his full diagnostic of the knee joint. Upon the completion of the full diagnostic, he will then insert a shaver and begin to remove all of the ACL ligament that is torn. He will mix in both the shaver and the vapor in and out to debride and get rid of the ACL ligament that is torn. Now that ligament will be torn. That ligament will be taken out all the way from top to bottom. When there is no more ligament left in the knee joint, he will then leave the knee joint and move to the scrub table, where he will then decide to shape the either autograft or allograft. When he finishes that, he will come back to the knee joint, put the scope back in, and just check over his work to make sure that all scar tissue and all of the ACL ligament has been removed from the knee joint. If not, he'll insert the shaver back in and just touch upon where he missed to make sure everything is removed. Now, after that, he will remove the shaver and insert a burr. The burr will be used to perform a notchplasty on the intercondylar notch to make it give more area for the new ligament coming in. So that way we have no impingement. When that is done, we will then insert a spinal needle through the anterior medial portal. So we'd be coming from the inside, and we would be lining it up right onto the lateral femoral condyle. That is where we will mark our spot for insertion of the femoral tunnel. So when we find our spot with the spinal needle, we will remove the spinal needle and insert a microfracture. Microfracture gets inserted, mallet gets used, about 1 or 2 knocks, and then you will have your set placement for where you're going to drill into. Excuse me. The doctor will then remove the microfracture and insert a beath pin. Now this is all preference. The beath pin will be drilled into the lateral femoral condyle a certain depth. That's what I was talking about with the preference. Okay. Last surgery I was in, doctor went 25 millimeters with the beath pin. Then the beath pin will be removed. Next, he will insert the reamer. The reamer will follow in that exact spot, and like I said, all preference. Last surgery I was in, doctor went 35 millimeters. So you're going to go past with the reamer, and you're going to take that all the way to the outside part of the femur. Now, after that tunnel is established, you'll do the same thing through the tibial tunnel. But you'll be drilling from the middle of the knee joint out. When that is done, the drill will be removed, and insertion of the shaver goes in one more time to remove anything that's sitting around the tunnels to make sure that nothing is blocking it. The doctor will then receive the graft, whether allo or autograft, and insert it through the tibial tunnel. Through the tibial tunnel, it will be attached to suture coming out of the femoral tunnel. So we'll go in through the tibial tunnel, and the doctor will pull up the tendon through the tibial tunnel to go through and then pull it through the femoral tunnel. When it gets to the femoral tunnel, there's a button that is attached onto the new tendon coming in, and the button goes up straight, and then when it reaches a certain point, the button will fold over and lock. That will hold the tension through the femoral tunnel of the ACL. That'll hold the tension in the femoral tunnel for the ACL ligament. Now, once that gets set into place, the doctor will be holding the sutures out of the tibial portal, and will be holding them so that the way there's tension on it. Then a PA or a resident will come by with a Milagro screw and screw in the Milagro screw into the tibia while there's tension on the sutures. This provides tension for the graft to stay in place. That way it won't fall or creep up. Once that is done, and doctor will then insert his or her scope back into the knee joint, and we'll check to see if there's any impingement between the notch. Make sure the ACL is sitting right and it's not being rubbed against on either side of the intercondylar notch. Once he sees that and notices that it's all good, he will then take out the scope and take the knee and put it into flexion position in and out. So you'll see the knee just constantly get put in and out to make sure the repair went well and everything is good. When that has been decided, doctor will clip the sutures. Will clip the suture hanging out of the femoral tunnel, and you can stitch up, and the ACL procedure is over. Not too bad. Thank you guys for watching. Have a wonderful weekend. See you guys next week.